So I'm now going to introduce our really excellent lineup of speakers and moderators that we have for this session today, who again you likely already know because they're all international leaders in behavioural trials, and they've all won many awards for their work and have been particularly influential in developing networks with decision makers to actually translate knowledge from behavioural science into policy and practice. So I'm really thrilled to be introducing these panelists today. So our speakers are Dr. Susan Mickey, Dr. Kim Lavoie, and Dr. Sherry Stewart. So Dr. Mickey is a Professor of Health Psychology at University College London in the UK and is Director of its Centre for Behaviour Change and its Health Psychology Research Group. Her research focuses on behaviour change in relation to health, particularly around the use of theory. So how do we advance theory in this area and how do we use it to understand behaviour change, develop behaviour change interventions? And her research particularly develops methods to advance the study of behaviour change, which is currently Principal Investigator of the Human Behaviour Change Project. Next up we'll have Dr. Lavoie, who is a full professor in the Department of Psychology and Chair of Behavioural Medicine at the Université du Québec à Montréal. She is also co-director of the Montreal Behavioural Medicine Centre and, as we know, co-lead of the IBTN network. She currently holds a Quebec Health Research Senior Investigator Award, and her research particularly focuses on the impact of psychological stress and lifestyle factors on chronic illness, on developing interventions in this area, where she has particular expertise in motivational communication. Our final speaker is Dr. Stewart, who's a Tier 1 Canada Research Chair in Addictions and Mental Health, and a Professor in the Departments of Psychiatry, Psychology and Neuroscience, and Community Health and Epidemiology at Dalhousie University in Halifax, Canada, where she founded the Centre for Addiction Research. Her research focuses on psychological and motivational factors contributing to emotional and addictive disorders and their co-occurrence, and on, again, evaluating interventions in this area. And our discussion today will be moderated by Dr. Michael Vallis and Dr. Robert West. Dr. Vallis is a health behaviour change consultant and an associate professor in family medicine, again at Dalhousie University. His main area of expertise is adult health psychology, with an emphasis on obesity, diabetes, cardiovascular risk, and gastroenterology. He's worked in the public health system for 35 years, where he developed the Behaviour Change Institute. He trains healthcare providers in behaviour change and is active in research on motivation, behaviour change, and adaptation to chronic disease. Our second moderator is Dr. West, who's a Professor of Health Psychology at University College London in the UK. He specialises in addiction and behaviour change and is Editor-in-Chief of the journal Addiction. His research focuses on areas such as evaluation of pharmacological and behavioural aids to smoking cessation and on understanding motivation. He's helped to create the blueprint for the UK's National Health Service Stop Smoking Services and has acted as an advisor to Public Health England in this area. So I'd now like to formally begin the session and invite Dr. Mickey to begin her presentation. And if we could get Dr. Mickey's slides loaded as well, that would be great.
Aha. Oh dear. No. Not quite sure how to make, oh dear, I'm so sorry.
If you...
It's a very tiny version in the middle of my screen.
If you want, Susan, you can change your view options at the top of Zoom, and you can, I believe you can remove yourself.
Hide self, okay.
And that might make it bigger.
I can hear Robert from next door coming to try and help me.
You can also stretch the screen, like if you just go to this edge of your screen, you can kind of make it wider or longer.
Yeah, like where the slides meet the camera, you can pull that across.
Yeah.
Is that it?
And then what you want to do.
So I'm getting some technical support from the moderator.
That's great. You've got a great moderator there.
Do you want to put it on? Yeah.
Is that it?
Is that all right? Is that
I don't know.
Yeah. Then if you just.
Yeah.
Yeah,
okay.
You're in control.
Right. Sorry about that technical hitch. And delighted to be past this session. My only sadness is we can't catch up over coffee and over a drink in the evening, but look forward to when we can. And to say this is slightly changed from a talk I gave yesterday to the United Nations on World Psychology Day. So apologies to anybody who saw it yesterday, because it's a bit similar. So here goes. What I'm wanting to do is take a behavioural perspective to limiting COVID-19 transmission. Just to say something about who I am, I'm director of the Centre for Behaviour Change, which has collaborations and networks all over the world, and does a lot of translation of science into policy and practice through various types of activities. In terms of COVID-19, I'm a member of the UK government's Behavioural Advisory Group, and I'm also a consultant advisor on behavioural science to the WHO. I thought you might be interested in terms of what we're doing in the UK. The group is about more than 12 psychologists, probably about 20 now actually. We have health psychologists, social psychologists, emergency psychologists, and also anthropologists, sociologists, behavioural scientists, and communication experts. And ministers and various aspects of government ask us questions, and we then draw on all the evidence we have to try and answer those questions. And obviously, we're lacking in kind of real-time evidence, although we have been running some experiments to look at, for example, the types of how best to present different kinds of tests. But we draw on what we can, as everybody is doing, published literature from other situations, unpublished reports, surveys, current surveys, as huge numbers of polls being conducted, interviews, focus groups, expert opinion. And just to give a flavour of the kind of papers that we produce, we've probably produced about 30 or so now, I think, but general ones such as how to improve adherence to government guidance, options for lifting or tightening restrictions, effective communication strategies, and then also more specific topics such as school closures, self-isolation, household isolation, social disorder and policing strategies. I think the government were a bit worried about that at the beginning. How best to present diagnostic and also antibody tests, managing deaths and funerals in lockdown situations, establishing social bubbles or micro-communities. As I say, that's just a few of them. And if anybody's interested, if you go on the website for Scientific Advisory Group and Emergencies, there's probably about 20 of these published, and I think another dozen or so going to be published tomorrow. There's been a real call to publish them more rapidly than has been happening previously, so I'm delighted that that's happening now. There's one of the things that's good about what we're doing is that we're at liberty to publish the papers that we, or build on the papers that we produce for the government into scientific papers. So here's an example of one paper that myself and Robert West led on, and we had it rapidly turned around and published in the British Journal of Health Psychology. So I want to say something about human behaviour and the way in which it's the root of transmission and also the key to suppression. Say something about the contribution that we can make, and also say something about using frameworks, models and diagrams to communicate across disciplines, across sectors. Find it very helpful. Now, in reducing the pandemic, obviously, governments have focused on isolation, so keeping vulnerable people and infected people physically away from others, and also social distancing, so staying at home except for essential journeys, banning gatherings, and closing non-essential shops and establishments where people congregate. And isolation and social distancing have been very effective in controlling epidemics, but obviously of enormous cost to people's livelihoods, their education, mental health, and also the economy. And the alternative is widespread and rigorous adherence to personal protective behaviours. And I'll say a little bit more about those. But those could potentially reduce the extent to which we rely on the disruptive top-down isolation and social distancing measures. Actually, not just potentially, they definitely do. And actually, if we could get those behaviours adopted at scale by the whole population, it would stop the pandemic dead in its tracks. Easier said than done, so bit of a challenge there. So these are the personal protective behaviours, or PPBs, as we're calling them, and we're all very familiar with them. Washing hands with soap, not touching the T-zone, eyes, nose, mouth, which is how the virus gets into the body, sneezing and coughing into tissues and disposing of them, and where appropriate in indoor enclosed spaces, wearing face masks, and social distancing. So we could solve a very big problem, i.e. a global pandemic, by changing these seemingly small behaviours at scale. So all of those who said, you know, it's only systems that we should be looking at upstream, etc. Actually, this really shows that it's human behaviour that's at the heart of causing and solving many problems. And to demonstrate how behaviour can have its effect in blocking transmission, I'm going to present a diagram that, again, Robert Weston, myself and colleagues developed. And it's available if people want to see it in Nature Human Behaviour. So here we have the basic pathway. We've got the person who's infected on the left-hand side and the person who potentially could be infected on that solid right-hand blob, top right-hand corner. And you can see the different pathways in which a virus can emanate from this infected individual and reach somebody else. Now, here we have a blue rectangle, and on the left are all the behaviours to do with the infected person, and on the right, the transmission route in terms of the person who's not yet infected. It's a shame I can't make this full screen so that I don't see myself and I can see this bigger, but never mind, let me see if I can read this. Oh, gosh, I can't. Enter full screen. No.
Hi, Susan. This is Guillaume from IBTN team. So yeah. Do you think your camera is too big? You see yourself too big?
Yeah, I want to get rid of myself.
So I think there's a way, maybe, you know, between your camera, yourself and the screen, there should be a little sweet spot with if you put your cursor on it, to just reduce, you can reduce or upgrade your screen.
Oh gosh, what does this do?
So it's like if you were, Susan, if you were making a table wider or thinner, there's like an imaginary line and you can kind of shrink your camera view.
I've got it. Technical.
All right, fantastic.
Thank you.
Right, sorry about that. I couldn't actually see the screen before. Okay, so what we have here are the green boxes, which is the use of tissues, and the purple boxes, which are the using masks as appropriate. Then we also have at the top there, maintaining physical distance. You see these arrows are where we're actually blocking the transmission route. Now in purple, there's washing the hands with soap or sanitizer, again blocking a route. Then we've got disinfecting surfaces, and that's an object, so that's going to be even more important as people return to the workplace. And then we've got not touching eyes, nose and mouth. Okay, so that's sort of building up what the transmission route is and what these behaviours are. And as you can see, if everybody was doing all these behaviours, those poor viruses would be stuck. They would be on their way out. The other thing that as behavioural scientists we can do is explain how different behaviours require different sorts of interventions. So here are the 4 behaviours I've been talking about. And if we think about washing hands with soap, this requires new routines and new rules. If then plans that we know are very effective ways of actually changing behaviour. If I'm in this situation, i.e. coming into a building or about to eat or prepare food, then I will wash my hands. So it's a way of really establishing new rules, establishing new habits. When it comes to not touching the T-zone, this is often an automatic habit. I mean, evidence suggests we're touching our faces more than 20 times an hour, often without realizing that we're doing it. So it's either automatic or we're responding to an urge such as an itch. So for that, an if-then rule wouldn't be appropriate. We need to develop an incompatible behavior, like keeping your hands below shoulder level, sitting on your hands, putting your hands in your pocket, clasping your hands, and then also thinking about wash your hands before and after. So there you've got a kind of a chain of behaviors that need to happen. Then obviously sneezing and coughing into tissues, it actually requires a tissue. How do we make sure we have tissues on us when we haven't got a lifetime habit of doing that, or some of us don't? So new routines, like every day when you check, do you have your keys in your purse in your pocket? Do you also have your tissues in your pocket? And then social distancing, more complex because it depends on other people, depends on your environmental situation that you're in. So you can see all of these requires a different type of analysis as to what's going on and a different kind of solution. And I want to say something about working with policymakers, with governments, and one of the main things I've learned over the years is that one actually has to be aware of the differing agendas, incentives and terminology between policymakers and scientists. And one of the other challenges, and one we're really faced with, I have to say, in the UK, is all that wonderful advice we're given on how to communicate and other such things. Do any of them actually translate through into policy and have an impact? Who knows? Some of the solutions I mentioned, I think using frameworks and models can be very helpful, and also using templates to structure what's quite complex information into actionable recommendations. Because I think that's something else we need to be very aware of, that we talk in very complicated ways, using very complicated terms, and policymakers really don't have the time or inclination to get involved with that. So we do have to make things really, really simple, obviously without dumbing down. A very simple model of behaviour, probably the simplest one that at the same time is comprehensive, has been developed from the experience of working with policymakers, COMBI standing for Capability, Opportunity, Motivation and Behaviour. And basically all of these things need to be in place if behaviour is to occur. And when one's thinking about intervening, there's obviously if you look, you see there's sort of feedback loops going in between those. So it can help guide which of these you target in which order. And then also those who are familiar with the behaviour change wheel, that has a series of intervention types and policy options that you can link the analysis of behaviour in its context using COMBI to the interventions and policies that are most likely to be effective for it. So that's really helpful, and if only all politicians and policymakers could just remember that, it would be excellent. And just to give an example from the UK as to this not happening, was in April. It was after a long wet winter, and it was the first weekend when the sun came out, absolutely gorgeous. Soon after the lockdown, of course, we went to the park and we were allowed to go out once a day for exercise. And so we went out, and then the media took lots of those sort of long distance lenses, which makes it look very, very packed. And then our health secretary made a threat and said if we're going to carry on doing that, they would close the parks. So error number one, the polling data showed, despite how the media were portraying it, there's only 2% of people who were breaking the lockdown, and 99% wanted to adhere to it. The reason that many people weren't keeping 2 meters apart was due to crowded open spaces, and the problem was opportunity rather than motivation. So they'd misread that. And so certainly when I've been on the media, I've been calling for things like opening up the 45,000 acres of private golf courses there are in London, and all the huge number of playing fields in private schools that are not being used at the moment. Sadly, the politicians don't seem to have acted on that, but it won't stop me calling for it. So area 3, if there's a problem, don't threaten people with punishment. So it was the wrong solution for the wrong problem. And if the UK government had actually worked with communities, co-created, co-developed, as we're all, basic ABC of our work, then we wouldn't be in the kind of problems we now are in, which is costing thousands of lives, and these are avoidable deaths. So finally, I just want to go and say something about communicating behavioural science. Working with the WHO, the key thing that they have been trying to think about in relation to encouraging member countries to use behavioural science data is to think about how to present it simply in a way that people can actually act on it. So large amounts of complex data are being circulated in the form of surveys and polls, but countries vary enormously in terms of the resources they have to interpret that data and translate the data into actionable recommendations that obviously can make a difference in practice. So the survey that WHO have been sharing is a global survey done by the organisation called CANTAR. It's COVID-19 National Barometer. And so enormous amounts of data come through from that. And previously the WHO had just been circulating that to countries, but realising that they thought nothing much was being done with it. So I've been brought in to think about how can we make this data more usable and useful to countries. So using this framework, we developed a template to first of all extract the key messages from the data per country. So we produce country-specific reports and also have country-specific dialogues to go through it. We then organise the messages into coherent categories, linked them to a model of behaviour and translated them into actionable policies. So our template questions, we separated out, and the survey is sort of all over the place, but we extract it into thinking about feeling, emotions like concern and anxiety, thinking, knowledge, risk perception, behaving, for example, health-related behaviours or media consumption. Then we've also looked at to what extent is the population adhering to guidance, and then using COMBI, what are the influences on that adherence? Is it capability and or opportunity and or motivation? Because that then can guide the countries in terms of the type of interventions and policies that are most likely to be effective. So just to give a tiny little bit of this template to give you a feel as to what we're doing, here's something taken from one of the Brazil reports just about feelings. We've got here feeling 1, feeling 2. So the second column here, the survey findings, Brazilians have relatively low levels of concern around health in relation to COVID. And then our next column is context and interpretation, which we may gather from the survey, from our own knowledge, from talking to other people. But just how can we understand any particular finding? So the context for this is that the country leadership consistently underplays the severity of the virus. And our application, our action point, was to communicate the severity of the pandemic using trustworthy sources about deaths, about overpowering the health service, about the future of the economy and quality of life in Brazil. And then the second feeling was concern about increasing sort of economic instability. But anyway, that gives you a sense. And obviously we go through all the thinking and the behaviours, but that's our structure. Okay, so in conclusion, pandemics are obviously global, So developing solutions also needs to be global, and we need to strengthen our international scientific and work and application. And, you know, if this pandemic has shown the world anything, it's that individuals are connected, communities are connected, and countries are connected. And we ignore that fact at our cost. And I do hope that some good will have come out of all the bad that we're currently experiencing. I hope I've shown you that behaviour is at the heart of transmitting COVID-19 and at the heart of suppressing it. And to most effectively change population-wide behaviour, we need to draw on the science of behaviour and behaviour change. And this is a huge challenge. I'm old enough that when I was young, you wouldn't think about sitting down to eat a meal without washing your hands in advance. Sadly, I failed to bring up my children in that way, partly because, you know, the cultural norm had changed, and we need to find ways of getting this back across the world. And finally, models and templates I find to be very useful in summarising and communicating what we know in an accessible way, and trying to translate scientific thinking and evidence into a form that's useful to those involved in policy and practice. And for any of you who want to find out a bit more about this, on the left is a Nature Human Behaviour paper that Robert West was first author of, and the other paper that I mentioned before, looking at options for increasing adherence to social distancing. And then 3 out of, I think it's now about 8 blogs in BMJ that myself and others have written with various aspects of behavioural science in relation to COVID-19. So I'm terribly sorry if I took more than 20 minutes with all my faffing around with the technical aspects of the presentation.
Not at all, Susan. Thank you so much. And I'm going to speed up a little bit, because I think my introduction is going to touch upon almost every point that you mentioned. So it'll be a nice segue into our international study, which I think is really following from a lot of the excellent points and comments that you've just made. So I'm really excited to present to everyone some preliminary results, very preliminary, so preliminary that I only finished my talk. I think mine was the last to upload yesterday. And I want to thank my fantastic team for helping me get this together. So I'm going to also present on behalf of the entire iCARE study team, and following from the previous session, I'm hoping to show you what can be accomplished in our fantastic behavioral medicine community in such a short time. So everything I'm going to present to you today began the last week of March, and this is the accumulation of 2 months worth of effort. I just want to say about my camera. My camera's on my laptop, but my big screen where I can see, a bit like Susan, I'm getting, you know, my eyes are getting weary. So you're going to see my profile, unfortunately, so it's just a little bit easier for me to present that way. All right, so these are my disclosures. I'm just going to put that on full view. There we go. That should work there. There we go. Advance. Perfect. So as Susan very well described, in the absence of a vaccine, a treatment, or cure, the key to slowing the spread of COVID is adherence to public health policies. But of course, these come with significant personal, social, and economic costs that might undermine adherence for a number of reasons. And we think that understanding the psychosocial determinants of adherence might help inform policy and communication strategies. So I think Susan really set us up well to understand this. Now, I think as well, we would all agree that there's a ton of insights to be gleaned from behavioral science around issues of threat perception, the leadership and the communication that's coming from our government authorities, the competing interests, our individual versus our collective interests, how messages are communicated, the context in which pandemics and responses and policies are being rolled out, and of course, individual differences in stress and coping, and how these can also be important motivators and barriers to adherence as well. So this is the birth of iCARE. And on March 11th, less than 2 weeks after returning from spring break in New York, so the last time Simon Bacon and I were in a restaurant was in New York City. And this was because our spring break in Montreal is quite early in the year, and we were there from roughly February 28th to March 3rd. And a few weeks after we returned home, the pandemic had really hit Montreal and our lockdown began. Now on March 18th, it became apparent that public adherence to the rapidly emerging and quickly evolving policies was really what was key to flattening the curve. And we saw this from what was coming out of the international news, and we just felt like we wanted to help. We felt like we needed to do something. So we said, we had this brilliant idea, let's put together an international team and create a behavioral science informed survey to answer the following research questions. What are the determinants, both sociodemographic, psychological, behavioral, physical, mental health, and economic determinants of COVID-19 related policy adherence? And even more importantly, what policies launched where, when, and for whom seem to be most and least associated with adherence and most and least effective at reducing infection rates and mortality? And of course, as Susan said, we really wanted to help provide more data-driven recommendations to local and international governments on how to optimize both policy and communication strategies, with obviously the ultimate goal to address the two major outcomes of COVID, and that is health outcomes and those related to the economy and quality of life. So we designed very quickly, record quickly, an international multi-wave cross-sectional observational cohort study. And we're doing sort of two kind of studies in parallel. One relies on global convenience snowball sampling. And we're also conducting representative sampling in target countries. And we're only doing this in certain subset of countries, primarily due to feasibility. But these countries, we've selected them to represent all the continents of the world, to be representative of all phases of the pandemic curve, as well as having representation from LMIC as well as high-income countries. And for feasibility, of course, we need a local investigator willing to take the lead on representative sampling. So these are the list of countries. I'm not going to go over this in too much detail right now, but just to show you that this is where the different countries find themselves on the pandemic curve. These are roughly the income strata of the different countries, and these are the continents. So I just want to thank the investigators listed here for taking a leadership role in the representative sampling. So we launched the first wave of the survey on March 27th, and the survey was really constructed and informed by the major modules, by the COM-B model and the health beliefs model. And the modules are as follows. We obviously asked about sociodemographics, and we've tried to align our questions with other international studies. And our study features among those being recognized by the OBSSR of NIH as being one of the international surveys with potentially harmonizable data. We ask questions about health status and health behaviors. To what degree are people aware of their local public health policies? To what degree are they adhering to them? We're also examining COVID-related concerns. And in wave 2, we added a module on COVID-19 related impacts, because we believe that as people are starting to feel the consequences of the pandemic, this is going to further serve to motivate behavior. We are also linking our survey data with country level policies, and we're bringing in Oxford policy tracker data. We're also looping in Johns Hopkins case, death, and recovery data, as well as Google mobility data. So as you can see, we're really bringing in a lot of data. And so unfortunately for today, I don't have the external data to link to the survey just yet, but stay tuned, things are coming out pretty quickly. I just wanted to show you here how we've roughly mapped on our survey questions to the COM-B model. Not to belabor the point, but things like people's health conditions, awareness, for example, of your country's policies would map onto psychological capabilities, for example. Obviously, certain sociodemographics would map onto physical and social opportunities. Motivators or concerns would reflect the motivation. So we've really made an effort to ensure that we're not just slapping a survey together. It's really informed by behavioral science theory that is solid and robust. This is roughly the survey schedule. So as I mentioned, we launched wave 1 of the global survey on March 27th, and we ended up with a total of 28,700 or so respondents around the world. We also, at the same time, got representative samples from Canada, Australia, and the UK. We launched wave 2 roughly the first week of May, and we're towards the end of our wave 2 data collection. And of course, wave 3 will be launched within the next couple of weeks. So progress to date, and now we're going to move right into the results. So when we launched on March 27th, we had 93 international collaborators from 26 countries, and we now have, at last count, I hope I have everyone, 158 international collaborators from 38 countries, and a survey that is now available in 36 languages. And we were able to get this together only because of the outstanding collaboration and goodwill and motivation on the part of all these international collaborators, and many of which weren't known to us before this endeavor. So I really want to thank them, and without the community, this wouldn't be possible. In terms of recruitment to date, and this is recruitment numbers from March 27th to May 6th, when we closed out wave 1. As I mentioned, over 28,000 respondents, including 7,000 from representative samples in wave 1. We had over 37 in total. And data to date, and this is as of a day or two ago, we had about 10,000 or so in our global sample, and another 7,000 or so projected in representative sampling. Now, I just want to say that so far we have managed to do all of this without any dedicated funding. So Simon and I and some of our collaborators have pulled together little bits of money. So everything you're seeing here is actually without any dedicated project funding, of which we have applied to. I'm going to present to you now some preliminary data, and we were able to pull some country data. And what we've tried to do is we've tried to pull in data from countries for which we believe we have enough data to say something meaningful. And we've also selected countries based on where they are in the world and where they are in the curve. So we're going to present to you data from North America, Canada and the US, South America, Brazil and Colombia, Europe, France and Italy, as well as Taiwan and Kenya. And all told, this represents about 15 or 16,000 of our 20,000 or so survey. So just to let you kind of give you a flavor for who we're talking about. So it would seem that of all of our global respondents, it's a primarily female sample, approximately 70%, with a mean age of around 41, mostly employed pre-COVID, mostly well-educated and either middle or upper income. 1/3 have a health condition that's a significant risk factor for COVID-19 related complications. These might include cardiovascular disease, chronic lung disease, autoimmune disease, high blood pressure, diabetes. 12% of our sample have identified as being essential service workers, so high risk of exposure. And of those respondents who said they got tested for COVID, nearly 11% said they tested positive. Now there's a ton of results. So what I did is I put a results plan so we can kind of keep it straight. And Simon and I took some time to really kind of streamline the results and pull out the things that I think are some of the more interesting things that we can present to you right away. So I'm going to talk about how people are perceiving government policies, adherence to prevention measures, the major ones, what are people's COVID-19 related concerns, what's the association between the strength of different types of concerns and behavioral adherence, and what seems to most likely motivate adherence. So when we ask people, what do you think of the actions taken by your government to prevent or reduce the spread of COVID-19? We find that fewer younger age groups are satisfied with the policies, and those from younger age groups seem to find them too lenient. So in the blue bars, you have under 29s, and then 30 to 69 is that sort of middle age group, and then the 70 plus is those seniors who seem to be more at risk. We also find, if you look at this by country, more people from basically Brazil, France, and the US find policies too lenient, which is quite interesting because of, I mean, it's interesting too that Susan just presented data on Brazil, and it would appear that our survey also seems to coincide with the feeling that the government responses in some countries, at least from the perspective of the population, may be inadequate. When we ask respondents, the frequency with which they've engaged with in each action or behavior in the last 7 days, what we find is overall, with the exception of wearing a mask, most people report adhering to the major prevention measures at least most of the time. So this is the 80% mark. And the red bar indicates those who indicating practicing hand washing and social distancing at least most of the time. So that's pretty good. I'm going to present you the flip side of this graph and draw your attention to the last item, and that is if you have tested COVID positive or you believe you have COVID-19, but weren't able to get a test, what proportion of those people report self-isolating? And globally, more than 16% of people with confirmed or suspected COVID worldwide report not self-isolating at least most of the time. So this is not all of the time, this is at least most of the time. So on a population level, this is certainly something that's of potential concern. One thing I'm going to come back to in my concluding statements is really one of the things we'd like to do next is understand who are these people and what are some of the barriers. When we also look at other demographics associated with adherence, we see that adherence appears to be worse among younger age groups. Might not be surprising compared to older age groups. Again, those are the blue bars here. And adherence appears to be better among higher income groups compared to lower. And again, this might relate back to issues of opportunity. When we look at country level data, a few interesting findings. Over 75% of people from all countries except Taiwan and Kenya appear to be social distancing at least most of the time. So this is, again, global data with the exception of those two countries here. In addition, at least 80% of all people from all countries appear to be hand washing at least most of the time. But interestingly, and this again covers the period from the end of March till about the 3rd week of April. Few countries at this time were wearing masks. Now this could be in part because there wasn't as much direction and policies around or recommendations around wearing masks, but interestingly, only those from Taiwan and Italy were doing this regularly. So if we're looking towards the future and bringing again Susan's presentation back in, it would seem that this is one of the non-habitual behaviors that might be really challenging to get people to do if this is something that we think is a good idea. Now, in terms of telling you a little bit about people's COVID-19 related concerns, the under 29s were most concerned about their personal health. However, they were less concerned with others' health, the economy, and getting back to normal compared to the older age groups. So again, the less than 29s, and this is compared to the 30s to the 70s, appear to show interesting differences here. And to me, this was a little unexpected, to be honest. If we look at concerns as a function of country, and I know there's a lot going on in this graph, so I tried to make it a little bit easier to understand. Interestingly, we see sort of a pattern in France and Canada, and I don't know if it's our links to France or I'm not sure what it is. But France and Canada together seem to have the highest relative levels of concerns overall, except for personal economic concerns here. However, Kenya, Brazil, and the US were among those with the lowest relative concerns for personal and others' health. And Kenya had the lowest concerns overall, i.e. they showed the lowest levels of concerns across all 5 categories. There we go. Now, one of the things we wanted to look at is statistically, what was the association between concern type and adherence to COVID-19 measures? So we were looking to see, were there certain concerns that seem to be more likely to motivate good adherence? And this is again, primarily to hand washing and social distancing. And as you can see here, interestingly, only economic concerns, and that's sort of concerns about my personal finances and about the general economy of my country and getting back to normal, were significant predictors of better adherence to prevention measures worldwide. And perhaps the strongest one was really this one here, and that is concerns for my economy. And this is interesting because this, again, you have to think about the temporal period of this data was really early on. So we're about a month after that, where obviously many more impacts and many more things have happened since then. And finally, we asked people what measures and policies would most convince you to practice social distancing. And of course, those behaviorists on the line may not be surprised by this, but we were really pleased to validate this. People worldwide told us that giving us information about how COVID-19 is spread, all those transmission routes that Susan very beautifully outlined in her talk and her paper, and in particular, telling me how my behavior is slowing the spread of the disease and how my behavior and to a large degree my sacrifices are saving lives in my community. And interestingly, this was reported consistently by 7 of the 8 countries. Only Colombia had a slight deviation from these as being the top 3 measures that would be most convincing. We also asked what measures would least convince you to practice social distancing and may actually have a counterproductive effect. Once again, we see the what I call the sticks rather than the carrots. So threatening people with quarantining them, threatening them with fines or arrest for non-compliance. And interestingly, this was universal. So these were the least endorsed measures by all 8 countries that I'm presenting to you today. So in summary, most people appear to be adhering to major preventive measures, in particular hand washing and social distancing, except Taiwan and Kenya, and only Taiwan and Kenya, and to some degree Italy, are wearing masks. Younger age groups seem to be less adherent than older age groups overall. Shockingly and a little concerningly, 16% of people who report having confirmed COVID-19 or who suspect having it are not self-isolating. Though people were generally concerned about their personal health, only economic concerns and getting back to normal were significant predictors of adherence. And reinforcing good behavior, in particular how behavior is saving lives, was more likely to motivate adherence than punishment. And this was true worldwide. So, and examples, there's a million, again, this is sort of put together yesterday, there's a million actionable recommendations I think we can glean from this preliminary data, and there's still so much more we need to look at. But some starting points is that public health messages should really provide information about how adherence is helping and how their behaviors are directly tied to blocking those transmission routes. And so we should also emphasize as well how behavior now can help the economy and get us all back to normal quicker. That seemed to be an important actionable step. Remaining issues and next steps is, I think, a challenge ahead is to increase mask wearing. I think we need to understand why so many COVID patients are not self-isolating, and how are the impacts of the pandemic affecting people over time. So I want to say thank you to our incredible MBMC staff and students involved in this project, in particular Guillaume, Genevieve, Ruth, Capria, and Liza, and Fanny and Joe at Wordcrafting, and our fantastic students, and of course all of our international collaborators. There's so many, community and so on. So thank you so much for your attention, and I turn it over to the next speaker.
Thanks very much, Kim. Thanks to both Kim and Susan for really fantastic talks. Such a wealth of information there about how we can apply behavioural science lessons to inform government responses to the pandemic. I'll now hand over to Sherry Stewart, who's our next speaker.
Thank you. I'm just going to try to figure out how I get control here. Okay. I'm just going to make sure this moves ahead. Yes, it does. Okay, well, I wanted to say, first of all, that I feel very honored to be part of this, this symposium today, and I appreciate the invitation from Kim and Simon to speak. We're going to be changing gears a little bit now, so we're still talking about behavioral reactions to the pandemic and health psychology related theme. However, we're switching gears to look at really maladaptive behavior, so drinking, in the context of the pandemic. So we're going to be looking at some gender differences today and links between mental health and substance use behavior, in particular alcohol, in the context of the pandemic. Okay, so as we've heard already today, we know that many countries, in an attempt to flatten the curve and manage the spread of the virus, have really adopted unprecedented restrictive viral contagion strategies, social distancing, quarantine, lockdown. And the real question today is what kind of effects does that have on people's mental health and on their health behaviors? And we do actually know, both from studies that are emerging worldwide with this pandemic and previous pandemics, that there are changes that happen. There's a major psychological impact of both of the pandemic itself and of our containment responses as a society. So just some examples. What do we know from SARS? We know that contamination fears increase, so perceptions of threat increase. We also know that for some individuals, psychological distress increases, both anxiety and depression. There was a nice review of 24 studies on the impacts of quarantine and lockdown procedures during a pandemic, bringing together 24 studies that have been done in this area. And the conclusion was that, the effects are variable across individuals, but overall quarantine and lockdown kind of procedures do have negative psychological impacts for some that are severe and are long lasting. What do we know then about people's health behaviors? And I'm going to focus in on alcohol use. A recent article in The Lancet really warned about increased alcohol use during the pandemic and how this was likely to be a major public health concern. And there's data now emerging to really support that. In the US, market research shows alcohol sales have increased about 55% in the US since the pandemic. Now, some of you might say, well, obviously people aren't going to restaurants, they're not drinking in their usual environments, so they're buying alcohol, or this might have been panic buying, worrying that the alcohol outlets would close. But when we look at survey research, for example, a study done by the Canadian Centre on Substance Use and Addiction here in Canada, they did a NANOS poll across Canada, showing that Canadians are drinking more. So the highest rate was 25% reported increasing their alcohol use in the 35 to 54-year-old age range, with 44% of those who reported that increase attributing that increase to stress. There's been another recent study that I just saw yesterday, across Canada study, suggesting even higher rates, so it's a little closer to 30%, reporting that their alcohol use has increased during the pandemic. We do know from previous pandemics like SARS that for some individuals, these changes in their health behaviors, like their substance use behavior, do persist beyond the pandemic. So this makes it of increasing concern. So patterns that are starting during the pandemic persisting. Now, in terms of why might this be, one theory that's relevant here is the self-medication hypothesis. So Krantzian has described this hypothesis as contending that people will increase their use of substances like alcohol to self-medicate for the distress that they're experiencing. So to manage negative emotions like anxiety or depression, or to manage perceived threats and stresses that they're experiencing. So when we apply this to the context of the pandemic, it does suggest that, on average, we should see increases in substance use and alcohol use due to self-medication, and that this should be particularly true for people that are experiencing more distress and more perceived threat in the context of the pandemic. What about gender differences? We wanted to take a look at this because there is some literature suggesting that there might be reasons to predict this might be particularly true for women. First of all, we know that emotional disorders, anxiety, depression, post-traumatic stress, all of which might motivate substance use, women have higher rates of those disorders. We also know from prior literature, there's a great book written by Steve Taylor on psychological reactions to pandemics that came out before this pandemic, and he summarizes the literature very well. And that's the one individual difference that's most consistent, is that women experience greater psychological distress in the context of the pandemic. In terms of the drinking literature, human and animal studies both suggest that women are more susceptible to stress-induced drinking. And in terms of motivations for drinking, while we don't see a lot of consistent gender differences in overall self-reports of drinking to cope, what we do see is that coping motives seem to be associated with heavier drinking more strongly in women than men. So that comes out of the largest worldwide study on drinking motives to be conducted to date, Kunch et al. So the aims of the present study were to test predictions of the self-medication hypothesis during this pandemic in terms of links of perceived threat around COVID-19 and psychological distress around COVID-19, that those two variables should be associated with greater alcohol use. And secondly, to explore gender differences to see whether this might be particularly true for women. So we hypothesized that we would see associations between our two measures of COVID-19 stressors, perceived threat and psychological distress, across with alcohol use, across 4 different indices of alcohol use, and that the above relations would be particularly strong in women. So our participants were a large American sample of adults. We particularly chose to match, to balance on gender. So 50% of the sample of 754 were women. On average, they were right in that age range, which the Nanos poll shows has the highest, increase in alcohol use. We were studying people who were in relations for another reason, who are in relationships. So the majority of people in this study were married. Most were white, most heterosexual, and about 2/3 of them had children at home during the pandemic. We did this between April 17th and 23rd through an online study hosted by Qualtrics Panel Surveys. They produced quite high quality survey data. There were 2 attention checks. They checked for IP addresses to make sure it's not the same person completing. They removed speeded responses. So this is all high quality data. The 2 measures that we used to look at COVID-19 stressors were the perceived coronavirus threat questionnaire short version. So it consisted of 3 items, and the coronavirus impacts questionnaire, the psychological subscale. So it was 2 items that assess psychological distress in response to COVID-19. And all of these items are completed on a 1 to 7 scale, where they say it's not true of me to very true of me. The first thing we did was make sure that these 2 scales are actually separable, assessing separable constructs with a factor analysis. And as you can see, they're clearly dividing into 2 different factors that are correlated, but moderately correlated, not too overlapping. Our alcohol use measures were, we looked in the past month. So this was all during social distancing lockdown, because it occurred in that week of April 17th. So we assessed with DIMEF's measure the maximum number of drinks during the heaviest recent drinking occasion during that last month, anywhere from 0 to 25. The number of drinks consumed on a typical drinking occasion in the last month, how often they were drinking in the past month, so the number of days that they consumed alcohol, and then the frequency of their heavy drinking episodes. So that was defined as 4+ drinks on a single occasion within 2 hours for a woman, or 5+ for men. And we looked at how often that was occurring over the last month. Here's our intercorrelation matrix. I think the first thing I want to point out to you is this is the gender column, and you can see that men are engaging in heavier consumption and more frequent consumption, as we already know. No gender differences in threat or distress, which was a little surprising to us. Threat and distress here, how correlated they are. As I mentioned, they're moderately correlated, but certainly not redundant constructs. What you can see here is this is threat, and this is distress. And you can see the 4 drinking variables are significantly correlated, a tendency for a stronger relationship with distress than for threat overall. Here are our means too, if you're interested. So on a 7-point scale, the average person is giving a rating of 4 for threat, a little lower at 3.5 for distress. Now, we predicted each one of these using a negative binomial regression model. So the first one I want to show you here is predicting the peak number of drinks on any one occasion. So their heaviest drinking episode in the last month, how many drinks did they consume? You can see men are drinking more on these heavy drinking episodes. COVID distress, as we have predicted, is showing a significant positive association. And we're seeing this distress by gender interaction that I want to show you here in a figure. So what you can see is that as COVID-related psychological distress increases, so does the peak number of drinks on the heaviest recent drinking occasion. But that's true only for women and not for men. And in fact, at low levels of psychological distress, we see the usual pattern that men are heavier consumers than women. But what happens at high levels of psychological distress? We see the women catching up or converging with the men. The next thing we wanted to predict was the number of drinks on a typical drinking occasion. Here we see men are drinking more on a typical drinking occasion, those in a relationship of shorter duration, those who have children in the home, which is a bit concerning during the pandemic. Again, distress is predicting as we hypothesized, and distress by gender. So we see that same interaction. Exactly the same as I showed you before. As psychological distress increases, so does the amount they're consuming on a typical drinking occasion. That's true only for women, not for men. Women catching up with men at high levels of distress. This is frequency, how often people are consuming alcohol. Gender is predictive, so men are drinking more frequently than women during this time, as we might expect. And distress is also predictive, but no interaction for this. Probably a little, I think the literature would suggest a little less concerning index of alcohol use in terms of its links with physical health consequences. And the number of heavy episodic heavy binge drinking occasions that occurred in the last month. Men are binge drinking more frequently. Younger people are binge drinking more frequently. Those in a shorter duration relationship. Again, concerningly, those with children at home. And here we see both perceived threat and distress are associated with increased consumption. And this time, gender is interacting with perceived threat. And it's that same nature of the relationship where the slope is only positive for women. It looks like it's significant for men, but it's not statistically so. And we see the women catching up with the men at higher levels of distress. So to summarize, we do see that psychological distress is consistently associated with increased drinking across all 4 of our indices of drinking during the pandemic. And perceived threat was also associated with increased binge drinking frequency over and above psychological distress. The effects were significant for women only for 3 of these relationships, and the ones on the more risky drinking indices, so the ones involving quantity. Having children at home, this was not a prediction of our study, but it was really interesting finding to emerge on both drinking quantity and heavy episodic drinking frequency. Those who have children at home are tending to drink more heavily. So to interpret these findings, are cross-sectional findings, so we don't know the directionality, but they certainly are consistent with predictions that come out of the self-medication hypothesis. And if we assume that directionality, it does seem that people are self-medicating primarily to manage psychological distress, but maybe also frequently drinking in a binge drinking manner to manage perceived threat as well around COVID-19. The fact that women were uniquely likely to increase their drinking in response to psychological distress and perceived threat is consistent with that literature I showed you before. And we don't really know why. It's possible that they're experiencing increased role strain between work and family conflict. So, during social distancing and stay-at-home orders, women may be working from the home, managing homeschooling, and having a lot of role conflict in those dual roles that they're not typically having in their normal lives outside of COVID-19. In terms of clinical implications, it seems quite important to continue monitoring of alcohol use, particularly in women, as the COVID-19 pandemic evolves. And women in particular should have some preventative interventions around alcohol problems. Like this is, quite concerning when you see women's levels of drinking catching up with men, because women will have more consequences physical consequences at the same level of alcohol consumption in terms of a risk for a number of diseases. And so we need to help women with training and alternative ways to manage psychological distress and perceived threat. And we need a lot more research about role strain, particularly when we're seeing those with children at home drinking more. And this could be a novel target for intervention in women if that proves to be an important mediating factor. And I just want to acknowledge my colleagues, Dr. Lindsay Rodriguez and Dr. Dana Litt. Lindsay Rodriguez is actually the lead investigator on this particular study. So she's at the University of South Florida. And thank Qualtrics for helping us with this, as well as the University of South Florida for funding this, and the Canada Research Chairs Program for funding my work. And if anybody needs my email, it's right there.
Thank you very much, Sherry. That was another fantastic presentation. Really important work you're doing there, and hopefully will be informative for working through how we actually support women, particularly through the COVID-19 pandemic. So thank you very much. So I'm going to hand over now to Michael Vallis and Robert West, who will moderate our discussion period. So we have just under half an hour for that till 12:05.
Hi, yeah. So I think, Michael, shall I take, what we're going to do is we've got loads of questions coming, and they've been very nicely sorted for us. So what I'll take the first one, and then we'll just alternate asking them on your behalf, and we'll try to get the broadest coverage. So and probably just I'm going to start with just doing it in order. So with Susan's talk, for example. Angela Fafmata, if I pronounce that right, asks, Susan mentioned the need for trustworthy sources to put out information in a way that can be understood by the public, but that requires inherent trust in the sources by the public. How can we increase and instill trust from the public in the process and product of science? And this is very relevant in the UK, where our government has clearly demonstrated itself to be completely untrustworthy. You're on mute.
You're on mute, Susan.
Was that one for me?
Yes.
So it's how to, it's a question about how to build trust and how to maintain trust, I suppose. And one thing that I think is really important is working with communities. Certainly in the UK, it's been a very top-down type of issuing of guidance and edicts. And I think that it's quite fragile, because if the trust is threatened in any way, as we've seen recently in the UK, there's nothing much underpinning it. Whereas if the government or whoever the sources, authorities are working closely with all communities, neighbourhood communities, working communities, demographic communities, then not only are they likely to have better guidance and more implementable guidance, but also there'll be shared ownership, and so people are more likely to implement it, and there'll be more trust in those who are giving the guidance. So there's several other things, but I think that's the thing that comes to my mind first.
And if I could just, Robert, sorry, just quickly interject just
Yeah.
a little iCARE tidbit. So one of the questions we did ask is, who are your major sources of information about COVID and policies and so on, of what you should be doing? And the top two ranked sources of information were still local health authorities and government, and particular, what I'm reading in the newspaper, hearing on the news, hearing on the radio. So these, around the world anyway, seem to be the top two sources, which means that, they're going to do the most, have the most benefit, or potentially have the most harms. So just wanted to compliment.
That's really interesting. And I was just going through your results. It was I was thinking, wow, we could really do with some of these results coming out here now. So we're going to use them like crazy. I just wanted, Sherry, did you want to say anything about that issue of trust before I hand over to Michael?
You're on mute, Sherry.
Thank you. I actually thought that I was taking it off. Thank you. I don't have much to add. I mean, I think that's a huge issue also with messaging around drinking, right? People are trusting information that's coming from sources that may not be reliable, and there was misinformation about drinking being beneficial and killing the virus, things like this. And so I think that this issue is very important in this area as well. And also, I think social norms are a part of what may be going on with this, these changes in drinking. Certainly with social media, you see tons of information about people normalizing that drinking with kids at home is okay. It's a good way to manage all of this. And so really normalizing that. And I think, that issue of trust in social norm information and lack of trust in the information that's coming from government is an issue as well in this area.
I wonder, Robert, if I could just ask or sort of make a comment and ask a sort of a related question. One of the things that struck me, Sherry, was how women's behavior is catching up to that of men. And I think most people were in couples. I was wondering if, well, listen, he's drinking. I got nothing else to do. I can't go to my yoga classes. I might as well just join him. And I'm wondering if there's a bit of a interplay between, or modeling and saying, well, geez, there's nothing else to do. And I'm wondering if that could be playing a role in that catch-up, those catch-up looking graphs that we saw.
Yeah, we actually just published, this is outside of the COVID, but we just published on mutual influences on drinking behavior, a meta-analysis on that very question. And actually, yeah, it is more true that women will be the ones that are, influencing. So this, I think you've got a good point, Kim. And we're actually launching, we're just funded and we're launching a study to look at that in couples. So this study was not, it was people who were in relationships, but they just participated on their own. And now we're going to do it with couples to see if that is something that's going on.
Well, I don't know if this is true of Susan and Robert, but I think it's more like Simon's catching up with me now, but we'll see how that plays out.
So maybe I'll pick up here. This is what an awesome presentation, a series of papers. I can't imagine having seen such data presented so quickly, but we've got an amazing demonstration of theory, method, and evidence from the behavioral sciences. Question here is, given the COVID-19 experience, how do we leverage this to embed behavioral scientists in the general decision-making and policy processes of government, given that most of the challenges in the world are behavioral in nature?
Susan, do you want to start?
First?
Yeah, I'm happy to start. I think it's given us a great opportunity to demonstrate the relevance of a way of thinking about problems and being able to bring, as you say, evidence, theory, and also methods for studying and answering questions. And I think the key thing will be how we manage to build on that. So I don't know about other countries, but we report to the Scientific Advisory Group in Emergencies, which is just set up for pandemics. I mean, this one I think will have quite a long life, but when I was on the H1N1 in 2009, I mean, it was less than a year that we were on it. But there I was the only behavioral scientist out of or social scientist out of about 14 scientists, and I managed to persuade them to set up a behavioral subgroup and pay for research assistant time, and we then got grants and wrote papers. And so that in fact is now chaired by somebody who came as a young researcher to work with me, and the group is 3 times as big, really excellent and more influential. So I think it's about showing a model of what can work, publishing as you go, so that it's not just lost in the depths of government corridors or whatever, and talking about it, ensuring that you take part in the media. I mean, certainly half a dozen of us in the UK have had a very high profile television and radio, and I think that's really important to establish what is a behavioural scientist? You know, why are they relevant to this? So I think it's been a fantastic opportunity for, you know, educating government, press, population at large, and we just need to build on it.
I have just sort of a comment and a question. From my perspective, I agree. I think the governments really don't understand the potential insights and contributions I think behavioral scientists can make. We could spend all day talking about why that might be, but I think one of the things that I think is going to be important to do if we do want governments to stand up and sort of listen to some of the things that we might have to offer is coming back to something, Susan, you mentioned in your talk, and that is you have to understand what their agendas are. And sometimes that's explicit and sometimes it's not. And I think, you know, certainly if it's me in the room, I definitely want to know, tell me what you care about, tell me what your agenda is, because I'm not going to be, I don't think I'm going to be able to influence you if I don't know what your, you know, quote unquote barriers are and motivators. And so I think it comes down to, again, sort of a model of shared decision making, but you need to understand where the other person is coming from. And governments are these massive organizations that are in huge conflicts of interest. And I think it's reflected in a lot of the, you know, contradictory policies and things that are coming out and are really confusing. I don't know about internationally. I mean, I can certainly, I see a lot of Canadian and American news, but there's a lot of confusion about what I should do and what I shouldn't do. And if the politicians aren't modeling the good behavior, it gives people a lot of excuses not to do it either. All of that to say, I think communication strategy, not just what you're saying, but just the overall strategy is critical. And as an international community around COVID, and where I think the scientists, all of us, not just behavioral scientists, but biological scientists and biomedical, I think we need to agree internationally on the criteria that the different countries need to kind of meet for things and restrictions to be loosened. And to me, even and someone who's watching this very closely, I don't think that that's really widely known, and certainly nothing's accepted across the different governments. So I think, to me anyway, I think that's going to be key, is to have those, that, you know, that transparency, so that, you know, we know what the barriers are for the politicians and the policymakers.
I don't really have anything. I agree with all the points made. I think just picking up on one other theme that was in your comment, Michael, was just the importance of theory. And you really see a lot of survey-based research on COVID-19 that's out there now, and people are quickly like pulling together questionnaires and getting them out there, but not all of them are theory driven. And what I kind of liked across the series of talks today was the real theory that drove the questions that were being asked. I really think that can lead to so much, you know, research that can really move things forward a lot better than non-theory driven research.
Thank you. That's great. I'll pass to Robert.
Yeah, actually, Sherry, there's a question directed at your presentation. Interesting one from Linda Carlson. It says, I agree that role strain between work and home schooling is a primary cause of stress for women at home now. And she asked, do you have data on who was working from home and who was not? And I should say that it was reported that in the UK that homeschooling was costing parents something in the region of $20,000, but $1,000 if they didn't drink.
Yeah, unfortunately, Linda, we don't have in this data set that data. In this study that's going forward with couples, we will have that data. We're asking about homeschooling, we're asking about role strain, we're seeing who's working from home, how long they've been doing it. Looks a lot more detail on those kind of questions that we'll be able to get at that issue. But this study actually wasn't designed as a COVID study. It was one of those, I think, like many people, it was something that was set to go. And when COVID happened, we put some measures in that were relevant. And so it didn't address all of the issues that I would have liked to if I designed this to really get at this question.
In the absence of data, psychologists are really good at speculating. I wonder if you might want to speculate on what you might expect, and then ask Kim and Susan to comment.
Sorry, could you ask the question again?
Yeah, just not having the data. I just wondered whether you might want to speculate. Yeah.
Yes. Well, first of all, I do think I do think that first of all, seeing that having children at home was associated with heavier consumption. I suspect that that is to do with homeschooling, and I do suspect that that has to do with that role strain of either that people are trying to manage if they're working in an essential service, coming back, teaching their kids, going back to work, or trying to manage their home environment to allow them to both work from home and manage homeschooling with their children. So that's an incredible, stressor. And so I do think that that's why and we also know that those duties, even though we've had, changes within our culture to make things a bit more egalitarian, we still know, like the most recent Stats Canada data show, that those duties do fall to women. And I'm sure during COVID, that's happening even more. So there's been quite a bit in the media anyway on the whole issue of the she session, that this is, these kind of things are really going to economically impact women more than men, and it's very concerning. And I'm sure those kind of things are also weighing on women's minds.
One thing I can add is about this working from home and having kids in the home, and we do have that data collected in iCARE. So I've already spoken to kind of Sherry offline. We do collect drinking behavior and how drinking is changing over time as through the different waves. It's not using a lot of those more sensitive measures in your previous study, because ours wasn't designed as a drinking study, but we do have a sense of how health behaviors in general. So we expect to see increasing in drinking, increasing in perhaps drug use, increasing in eating, decreases in physical activity, and so on. So, we do collect a lot of that health behavior data. We are also looking at vaccine history and vaccine intentions. I didn't present that data today, but we do have that as well. So I think that there's a lot of really interesting things. And of course, there's a lot of iCARE collaborators on the panel, on the call. And of course, we're open for business, as they say. So I think there's a lot of things that we can start digging into in the iCARE data as well.
So I don't really like to speculate without any data. So I'll draw on a N of 1 study. The participants are 64-year-old woman living in London. And the results of that N of 1 study, I think are twofold, and it may generalize to others. One is that it's actually quite boring. There's much less variety in a day than there is when you go into work, you travel, you listen to what other people are saying on the bus, or you even talk to them, you go in and out of shops. There's a lot of variation going from office to office, meeting different people within a day. Whereas if you're in the same environment for a lot of the day, it's actually, there's less stimulation and variety. The other thing is that, it's sort of 24/7. It's a bit weird, because the day is punctuated temporarily by being out the house, meals out the house, various things happening. And there's very much a coming home in the evening, which is, well, you don't always leave work behind, but at least for some periods, and you either might come home and you might go to the gym or, do something different, but you're home and there's been a break between work and home. Whereas this, well, you're still in the same room. You might move from one side of the room to the other, or, if you're lucky, from one room to another room. But I think there's something about punctuating the end of a working day and signaling an evening and relaxation. And, when the options are limited, there's that bottle of wine.
Yeah, Susan, can I just add to that? I totally agree. So, I think my whole talk was focused around one motivation, which is coping, but there are many more motivations that can be risky motivations that can be happening during a pandemic. So, managing boredom, need for stimulation, alcohol will, give you that rush and that excitement feeling, right? So I think, and I bet there's individual differences as well, because we know there's individual personality influences why people drink, and I bet it influences why they drink under a pandemic as well.
Great, thanks. I'll maybe at this point, we've got about 10 minutes left before we have to end the session. So I think I'll ask a fairly, probably a brief question to Kim, just so that a good opportunity. You kind of alluded to this in your comment just a minute ago, but someone has asked, are there still opportunities to join the iCARE study, get a new country or a new language involved? Can you just let the audience know?
Absolutely. Just get in touch with me or a member of the IBTN staff, probably Jen Chapanik if you can. And yeah, we're definitely open for more collaborators in more countries. Absolutely. It's really, we're thrilled to mobilize the behavioral medicine community, and we're definitely open for business.
Great, great. Okay, thank you. Thanks for that. Sherry, could I just ask you, could you comment on the public health implications of women kind of equaling men in their drinking behavior under conditions like this, and just what kind of a risk this might provide or present to the public health?
Yeah, so I mentioned that there was this paper in the Lancet kind of warning about the public health implications of increased alcohol consumption during the pandemic. And I think our data shows that that's particularly concerning for women who are highly distressed during the pandemic. And that this is of concern, like that you know, catching up for, you know, number of drinks that they consume on a heavy drinking episode, just as one example. We know that men and women, their body's ability to tolerate the same amount of alcohol, it's not equal. And so you get, you know, with similar levels of alcohol consumption, you have a higher risk for women for many diseases, you know, cancers, heart disease, many. So that was really concerning. When I looked at the figures, that was the first thing that kind of jumped out at me, was that, wow, you know, we hear about gender convergence just in general, that women are kind of catching up to men in alcohol consumption. And here was an example of when it occurs, right? And potentially starting to look at why it occurs. Like the pandemic might give us a model for why this is happening, but certainly, you know, very, very concerning from a public health perspective.
Okay. Any other comments on that from other panel members?
There's loads of really cool questions, and obviously we're not going to be able to get to them all. And I do apologise for you know, if we don't get to them. But I'm just wondering whether the organisers might pass the questions on so that they can. One of the great things about this kind of way of doing it is they can be answered offline and maybe distributed with the materials. I think that'd be really cool. But one that I think would be particularly interested. I think people would be interested to get people's speakers' views on is around social norms from Bridget Voisile. She was wondering whether you could comment on the role of norms in relation to adherence to the recommendations, and particularly this thorny issue, well, it is in this country anyway, I don't know if it is in Canada, of face masks, which are obviously hugely different across different countries in terms of whether they're normative or not, irrespective of whether they're effective obviously they're effective if they're used properly, but you know, whether they're genuinely effective or potentially even harmful if they're not. So I just wondered, you know, maybe start with Kim. Did you want to?
Sure. I think it's a great question, and in fact, there's some unique aspects about mask wearing that make it an interesting behavior to study. One is that it's not automatic. It's not something we're used to doing. It's a new behavior we'd be asking most people to do. The second thing is, I think what masks tend to signal, or what they represent for a lot of people, and certainly a lot of the masks that we've seen, you know, it signals infection or medical or, you know, healthcare personnel, and it's overall negative. Okay, so I think that there's a little bit of, you know, I remember when I was in New York City for spring break a couple months ago, and no one was wearing masks, but there was one taxi driver that was, and I remember being very aware that my reflection was, oh my God, is he sick? Because I knew that you're only supposed to wear a mask if you're sick. And I was like, do I take the taxi or not? So I wonder if that might be playing into it as well. Another interesting aspect about adherence to mask wearing and where social norms can come in is, like social distancing, you can't hide it. So it's explicit, and it's overt, and if you're doing it, everybody knows it, and if you're not doing it, everybody knows it. And I think if we can build it into the norms and make it more normative, I think, like social distancing to some degree, we can get more people to adhere. And again, I think it's going to be challenging for the reasons that I just mentioned. In addition to the fact that the recommendations are confusing. I can speak for Canada very quickly. They say we really strongly recommend it, but it's still optional. So I think that lends a lot of confusion.
Yeah, and I think there's an issue around how people use that. I don't know about in Canada, but in the UK, actually, and I've seen on pictures of other countries, I mean, the mask wearing is laughable, really. I mean, in terms of how people use it. I mean, it's almost as though people use it as a talisman rather than anything else. I've got the mask and it's going to give me some sort of magical protection. Sherry, I wondered if you had any thoughts about that or comments on this normative aspect and the role.
Yeah. I am on. Okay. Yes, I think that's really important in the alcohol area. Certainly something, again, people are talking about their own N of 1 studies, but I have seen on social media just tons of normalizing images and posts around drinking during the pandemic. And, some of them are using humor, like, mums drinking while they're trying to work and while they're trying to manage their children's homeschooling. And so it's quite concerning, like, often humor just reflects what's happening in society, right? So that these are like normative social norms, information that's getting out there. And so, but I don't see sort of the equal, once in a while I see something coming from CCSA, just kind of reminding people of, the moderate drinking recommendations, but that has not been as prevalent as what I've seen in terms of social norms around normalizing drinking during this time. So we're just actually starting a study about that, about posting and who's doing it and how is it related to drinking and to distress. But I think it's an important issue.
Thanks. Susan?
Yeah, I'll just be a bit deviant and not talk about social norms and go back to masks, but we'll end on the issue of behaviour, because as we all know, it's pretty well an evidence-free zone in terms of the effectiveness of masks in community settings. And so people are adopting it for different reasons, and some of it's, I think, to do with identity, some of it's to do with anxiety. But one of the things I think is really important is the difference between the effectiveness of masks when you try them out in laboratories in controlled conditions and can prove, look, X% of the virus droplets and aerosols don't get through this mask, is completely different than what happens in real time, in real context, with real people wearing them. And I think that's, again, where behavioural scientists can come in. Yes, if the right kind of masks are worn in the right kind of way and taken off and disposed of in the right kind of way, they are likely to be effective. However, the reality is that people fiddle with their masks and touch them when they take them off. And masks are a fantastic collector of virus because of the warm, damp atmosphere one creates on the inside of the mask. And unless they're thrown away, which obviously is very wasteful in terms of plastic and pollution, or put straight into a hot soapy water, then they can be put on a surface and the whole thing becomes a new viral transmission where people touch their mask, get the virus on their hands, touch other surfaces, the mask touch other surfaces, and so you're actually increasing risk of transmission. And the other concern is about people feeling safe, even though it's meant to be to protect other people. I think often people feel safer themselves, and so there may be less attention to social distancing and other personal protective behaviours. And certainly when I was in Japan a couple of years ago, I remember a woman saying her mother wore her mask 24/7, wore it all night in bed because she felt unsafe without her mask on. So I think it's a really nice illustration of how you absolutely have to understand behaviour if you're going to come to a rounded conclusion about when and for whom masks are likely to be effective.
And just to add on, some of the data I presented would suggest that among the 0 to 29 age group, if that's your target group, they're not so concerned about protecting others. So I think that if this is something that we want people to do, and I agree with Susan, I'm personally ambivalent about masks because the data is all over the place. You know, we've got to think about what is likely to motivate. And if the message is protect your community, wear a mask, with all the sacrifices and inconveniences that come with that, it may be extremely challenging.
That's a really good point. I think it may be one of these areas where you have to see a given behavior in a broader context, and the intervention as a broader intervention. So rather than just a simple recommendation about face masks, it would have to come with education, training, maybe environmental change to facilitate safe disposal. You know, kind of the way you might think about an ITU, where, you know, it's all set up for donning protective equipment and safely taking it off again, and so on. So anyway, handing over to Michael will probably be the last round, I'm guessing.
Okay, so there's a really interesting kind of question here. I think it puts a great sort of context and raises kind of social justice issue with regard to behavioral science. And there's a long history of hated minorities being blamed for epidemics, and the animosity often turns into violence and persecution. There are examples of this phenomenon starting to pop up in the COVID pandemic. How should the behavioral science community view this? Should we be trying to do something to address this issue? And I'll let anyone respond.
Well, I'll start with a very basic issue about the importance of showing commonalities across groups and showing shared identity and shared situations. And what we've seen in a pandemic and what we see in crisis situations is not what people often say, which is that things, you know, people show themselves up as selfish and greedy, etc. That's not what happens. It brings out the best in humanity. And you see incredible acts of collective solidarity and generosity. And I think it brings people together, and people suddenly focus on, you know, we're all in this together, we're all facing the same threat, the same situation, how can we help each other? And this is, you know, hardwired into ourselves. And I think, sadly, the kind of individualistic, consumeristic, harsh capitalist societies that a lot of us live in really squash those kind of sentiments. And again, one of the things I hope, you know, the positives, the silver linings that might come out of this, I mean, it so much depends on the agency and how we go forwards in our communities and try and shape a new kind of world. But one of our objectives should be trying to shape not only one that's better for the planet, but a kinder, more caring kind of world where people are really looking out for each other, whoever the other is.
Yeah, I agree. And that was well said, Susan. I also think too that I think it is a minority of people who are blaming and pointing fingers. And I think it doesn't necessarily represent the majority view. And I think and I noticed I've been kind of following the questions as well. And I think it speaks as well to what's being publicized in the media, what's being touted by governments, and not just fake news, but fake information that's coming from the highest authorities that could be advertently or inadvertently fueling some of these social issues. And I think it's extremely important. And I think it's important for more than behavioral science. I think it's important for communities everywhere to stand up and hold their governments accountable for potentially inciting some of this absolute nonsense. And so I think that we're part of that information and scientific base. But I think this is a community issue, not just a scientific community issue. And I do believe, as Susan does, that it's a minority of people, but unfortunately it gets a lot of attention. But it's extremely important to answer the question. It's extremely important, but I think we should all collectively be standing up against those fallacies.
Thank you. Sherry, any comments?
I completely agree with everything I've just heard. And I think I just wanted to point out the difference between the minority who are blaming and angry, and possibly more that are fearful. So that xenophobia. So once again, like you talked, Kim, about, you know, the mask being something that you can see that immediately instills fear. And I think there's some data to show, like across pandemics, that people start to fear where the virus originated from, and they so those kind of things might not be so explicit blaming, anger, but they might be nonetheless things that are creating stereotypes and stigmatization of different groups. So that's, I think, a responsibility that we have to educate and to try to combat that as well, the xenophobia.
And one thing
Thanks.
too that seemed to come out in iCARE is that struck me, or that's striking me so far, because as I said, we're just really starting to look under the surface, is how similar the concerns and how similar the behaviors and intentions are and motivators are across people. I mean, we had this, I presented a snapshot, but some of the general analyses that weren't country specific are on the whole population, which includes data from 143 countries. So I couldn't present it by 143 countries, but it's kind of incredible when you do those cross-country comparisons, is really how similar we are rather than how different, despite all of the apparent differences, contextually and otherwise. So that was really kind of nice to see.
Awesome. Thank you so much. We still have quite a few questions, but we unfortunately are out of time. So we'll have to bring this session to a close. I'd like to thank you all for presenting. Amazing amount of work. Remarkable how quickly this highly organized information has been put together, and just what a wonderful demonstration of the power of behavioral science. So thank you, everybody. And, I guess we go to a break now, do we?
Yep.
Yeah,
Thank you, everyone.
Bye.
Thanks, everyone.
It's lunch or dinner.
It's Nicola here. I've got a few notes just to reminders before we go on our break. Just want to thank all the panelists, our speakers and our discussants for, as Michael had said, this has been an absolutely fantastic session. There's so much of behavioural science that is applicable to this pandemic. As Susan had said, behaviour is at the centre of everything related to the pandemic. So fantastic to hear about this amazing work, and also want to thank the audience for posing such fantastic questions. Just to note that the IBTN team are collating those questions, and the answers will be posted on the IBTN website in the future. Our next session on methodological innovations and updates will begin in about 45 minutes at 1 p.m. Eastern Time. And just another final reminder that the link for tomorrow's sessions will be sent at the end of the day today. Thank you, everyone.